Here is something that stopped me cold during a cardiology conference last year. A cardiologist stood at the podium, looked out at a room full of physicians, and said this: "We have been giving seniors a blood pressure target for decades, and for many of them, hitting that target may actually be making things worse." And the room went quiet, not because it was controversial, but because deep down, most of us already suspected it was true. If you are over 50, if you take blood pressure medication, if your doctor has ever told you that your goal is 120 over 80, I need you to stay with me right now, because what I'm about to share with you is not just an update, it is a shift in how modern cardiology thinks about blood pressure, aging, and what it actually means to protect your heart and your brain as you get older. My name is Dr. William Lee, and I have spent over 2 decades working with patients in internal medicine and cardiovascular health. The reason I started this channel, BioSecrets, is simple. There is too much important medical information that never makes it out of conference rooms and clinical journals. It stays there, locked away, while millions of people are living by outdated rules that no longer serve them. That is not acceptable to me. So if you are new here, and this kind of honest, science-based conversation is what you have been looking for, I would genuinely encourage you to subscribe right now, because this is exactly what we do here every single week. Now, let me be clear about something before we go any further. Blood pressure management is still one of the most important things you can do for your long-term health. Uncontrolled high blood pressure is still a serious, life-threatening condition. I am not here to tell you to throw away your medication or ignore your doctor. What I am here to tell you is that the conversation around blood pressure has evolved significantly. And if you are over 50, the old rules simply do not apply to you the way they once did. So in this video, I am going to walk you through 5 critical things that have changed in how doctors now think about blood pressure in older adults. We are going to go from number 5 down to number 1. And I will tell you right now, by the time we reach number 1, you will understand something about your own body and your own cardiovascular risk that most people your age have never been told. Let us get into it. Number 5, the 120/80 standard was never designed with you in mind. Most people over 50 grew up hearing that 120 over 80 is the gold standard for blood pressure. Perfect. Normal, the goal. And for a long time, medicine accepted that as universal truth. But here's the part of the story that almost nobody talks about. The research that established 120 over 80 as the ideal target was largely conducted on younger, middle-aged adults. When those same numbers were applied broadly to older populations, something unexpected started happening. Some patients, particularly those in their 60s, 70s, and beyond, began experiencing dizziness, falls, fainting episodes, and in some cases, cognitive decline, not because their blood pressure was too high, but because it had been driven too low, too aggressively. Think about what blood pressure actually is. It is the force your heart uses to push blood through your arteries to every organ in your body, your kidneys, your brain, your eyes, your legs. When you are young, your arteries are elastic, flexible, almost like new rubber tubing. They expand and contract easily, and blood flows smoothly even at lower pressures. But as we age, those arteries naturally become stiffer. They lose some of that elasticity. And when that happens, your body actually needs a slightly higher pressure to maintain adequate blood flow, especially to your brain. Imagine you are trying to water a garden through a hose. When the hose is flexible and open, normal water pressure does the job perfectly. But if that hose becomes stiff and slightly narrowed, you need a little more pressure to get the same water to the same flowers at the end of the line. Your cardiovascular system works the same way after 50. So when older patients are pushed aggressively to hit 120 over 80, the risk is that the brain is not getting enough blood, particularly when they stand up quickly, when they walk upstairs, or when they are under any kind of physical stress. The result can be lightheadedness, loss of balance, or falls. And for someone over 65, a fall is not a minor inconvenience. Falls are one of the leading causes of serious injury and hospitalization in older adults. The actionable step here is straightforward. If you are over 60, ask your doctor specifically, what is my individualized blood pressure target given my age? Not what is the general target. Your target, because the answer for you may be different from what you have always assumed. Number 4, your diastolic number tells a story most doctors skip over. When you get your blood pressure reading, you see 2 numbers. The top number, systolic, gets almost all of the attention. It is the one your doctor talks about. The one medication is often aimed at reducing, and the one you will find in almost every headline about blood pressure. But the bottom number, the diastolic, is quietly telling a story that cardiologists are paying much closer attention to now, especially in people over 50. Here is what those numbers actually mean. The systolic pressure is the force inside your arteries when your heart beats and pushes blood out. The diastolic is the pressure that remains when your heart is at rest between beats. For decades, the concern was always about both numbers being too high. But newer research has revealed something that is genuinely important for older adults. Having a diastolic pressure that is too low, particularly below 60, can be just as dangerous as having one that is too high. This is sometimes called the J curve phenomenon in cardiology. Think of it as a curve shaped like the letter J. As diastolic pressure comes down, cardiovascular risk decreases. That is the straight part of the J. But at a certain point, when the diastolic drops too low, the risk starts climbing again. That is the curve at the bottom of the J. And the concern is that overly aggressive blood pressure medication, particularly in older patients, can push diastolic pressure into that dangerous lower zone. Why does this matter so much? Because your heart itself receives its own blood supply through the coronary arteries almost entirely during diastole, during the resting phase between beats. If diastolic pressure is too low, your heart muscle may not be receiving adequate oxygen and nutrients between each contraction. Over time, that is a setup for ischemia, essentially a slow starvation of the heart muscle, which can increase the risk of a heart attack even in someone whose systolic pressure looks perfectly controlled. The real world comparison I give my patients is this. Imagine a pump that has to refuel itself between strokes. If it does not get enough fuel during that resting moment, it will eventually start working less efficiently, and over time, it can fail. That is your heart when diastolic pressure is chronically too low. The practical step here, the next time you check your blood pressure, do not just look at that top number. Write down both numbers. If your diastolic is consistently sitting below 65, bring that to your doctor's attention and have a direct conversation about whether your current medications need to be reconsidered. Number 3, blood pressure variability matters more than a single reading. I want to tell you about a pattern I have seen more times than I can count. A patient comes in, sits down in the exam room, the nurse takes their blood pressure and it reads 148/90. The patient looks at me and says, "It is always fine at home." And I used to wonder which reading is the truth, but now we understand something much more nuanced. The truth is in the variation itself. Blood pressure is not a fixed number. It changes constantly throughout the day, sometimes by 20 or 30 points within just a few hours. It rises when you wake up in the morning. It responds to stress, to meals, to physical activity, to your emotional state, to whether you slept well the night before. A single reading in a doctor's office captured in one moment in time is one piece of data. It tells part of the story, but it does not tell you what your blood pressure is doing the other 23 hours and 55 minutes of the day. What cardiologists are increasingly focused on now is something called blood pressure variability, how much your numbers fluctuate over time. And research in this area has shown that people whose blood pressure swings dramatically, even if the average seems acceptable, have a significantly higher risk of stroke, heart attack, and cognitive decline compared to people with stable, consistent readings, even if those stable readings are slightly higher on average. Here's how I explain it to patients. Imagine you are driving on the highway. One driver maintains a steady speed of 65 miles per hour. Another driver constantly accelerates to 85 and then brakes down to 45 and then accelerates again. Both drivers may average the same speed over the journey. But which car, which engine, which brakes, which tires takes more damage? The one with constant, unpredictable surges. Your arteries work the same way. Each time blood pressure spikes suddenly and then drops back down, there is mechanical stress on the arterial wall. Over years, those repeated stress events cause damage, microtears, inflammation, and the kind of arterial injury that accelerates plaque buildup and increases stroke risk. And this matters even more for people over 50 because aging arteries are already less resilient. They have less capacity to absorb those surges without sustaining damage. The actionable step here is something you can actually do starting today. Consider monitoring your blood pressure at home, not just once, but at the same 2 or 3 times each day for at least 1 to 2 weeks. Track those numbers. Note the time of day, whether you have eaten, how you slept. Bring that log to your doctor. A 2-week home blood pressure log is sometimes more diagnostically valuable than 6 office readings spread across a year. Number two, the connection between blood pressure and brain health is stronger than most patients know. Now, I want to shift focus slightly because this next point is the one that, in my experience, genuinely surprises people. And in many cases, it motivates them to take blood pressure more seriously than anything else I could tell them. Most people think of blood pressure primarily as a heart issue. It affects the heart, the arteries, the risk of heart attack. All of that is true. But there is a second organ that is profoundly, deeply, and sometimes irreversibly affected by uncontrolled or poorly managed blood pressure. And that organ is your brain. The brain is one of the most metabolically demanding organs in the human body. It makes up roughly 2% of your body weight, but consumes about 20% of your cardiac output, the blood your heart pumps with every beat. It requires a constant, stable, well-regulated supply of oxygen and nutrients to function properly, and it is exquisitely sensitive to disruptions in that supply. Chronic high blood pressure causes damage to the small, delicate blood vessels inside the brain vessels that are sometimes no wider than a single strand of hair. Over time, that damage leads to tiny areas of injury called white matter lesions or small vessel disease. These changes do not show up as a dramatic stroke. They are silent, gradual, almost invisible on a day-to-day basis, but they accumulate. And the clinical outcome of decades of accumulated small vessel damage in the brain is something that cardiologists and neurologists are now treating as one of the most preventable causes of cognitive decline and dementia in adults over 60. Let me put that in language that I think lands a little harder. Vascular dementia caused by reduced or disrupted blood flow to the brain, is the second most common form of dementia after Alzheimer's disease. And unlike Alzheimer's, where our ability to intervene is still very limited, vascular cognitive decline has a clearly modifiable risk factor sitting right at the center of it: blood pressure. That means the choices you make about your blood pressure today, the consistency of treatment, the accuracy of your target, the management of variability have a direct bearing on the sharpness of your mind 10 or 15 years from now. But here's the other side of this that ties back to everything I said earlier. Just as chronically high blood pressure damages the brain, so does aggressively low blood pressure in older adults, particularly during sleep. Studies examining nocturnal blood pressure have shown that older adults whose blood pressure drops excessively during the night, a pattern sometimes worsened by evening doses of certain medications, show accelerated white matter changes and worse cognitive outcomes over time. This is why the goal is not simply lower is always better. The goal is optimal, stable, individualized. The practical step here is one I feel strongly about. If you are over 55 and you have had high blood pressure for more than 5 years, ask your doctor about a 24-hour ambulatory blood pressure monitor. This is a device you wear for a full day and night that records your pressure at regular intervals. It captures the nighttime dip, the morning surge, and the variability throughout the day. It provides information that a regular office reading simply cannot, and it could reveal patterns that change your treatment plan entirely. Number one, the real goal is not a number, it is biological resilience. I have saved this for last deliberately because this is where modern cardiology has made the most important conceptual shift, and it is the one that I believe has the greatest potential to change how you think about your own health. For generations, medicine was focused on hitting targets. Get the cholesterol below this number, get the blood pressure below that number, reach the goal, check the box, reduce the risk. And there is value in that framework. I am not dismissing it. Targets exist because they are based on real data about real risk. But there is a deeper truth that is emerging from the science of aging and cardiovascular medicine, and it is this: the number itself is not the full story. What matters most is the biological condition of the system behind the number. Two people can both have a blood pressure of 130/78. On paper, they look identical. But one of them has flexible, healthy arteries with strong endothelial function. The inner lining of the blood vessels is intact, resilient, and anti-inflammatory. The other person has stiff, inflamed arteries with damaged endothelial cells, impaired nitric oxide production, and early signs of arterial calcification. These two people carry completely different cardiovascular risks, even though their numbers are the same. This is what we mean when we talk about biological resilience. It is not just the pressure reading, it is the health of the entire circulatory system. And the good news, and I genuinely mean this, is that the factors that determine biological arterial resilience are, to a remarkable degree, within your control, even at 60, 65, or 70 years old. Let me walk you through what the research consistently tells us matters most. The first is sleep, not just getting enough hours, but getting quality, uninterrupted sleep. During slow wave deep sleep, blood pressure naturally dips, and that nightly dip is essential for arterial repair and recovery. People who consistently sleep poorly have stiffer arteries and higher nighttime blood pressure patterns that accelerate vascular aging. Sleep is not optional maintenance. It is active cardiovascular therapy happening while you rest. The second is what cardiologists sometimes call dietary nitrate. And this sounds technical, but the practical application is simple. Foods like beets, leafy greens, arugula, and even dark chocolate provide compounds that your body converts into nitric oxide, a molecule that causes blood vessels to relax and dilate, reducing pressure naturally and improving endothelial health. This is not a substitute for medication, but it is a genuine science-supported biological mechanism that works in your favor when you use it consistently. The third is the role of chronic low-grade inflammation. Inflammation in the arterial wall is now understood to be a central driver of arterial stiffness, plaque formation, and elevated blood pressure, not just a consequence of it. And the factors that drive that inflammation, poor sleep, ultra-processed foods, physical inactivity, chronic psychological stress, excess visceral fat, are the same factors that accelerate cardiovascular aging. Addressing inflammation is not about taking a supplement. It is about the cumulative effect of daily decisions that either protect or erode your vascular health. And the fourth, the one I want to leave you with, is movement. Not intense, punishing exercise, not running marathons. For people over 50, consistent, moderate movement, walking, swimming, gentle resistance training is one of the most powerful tools we have for maintaining arterial flexibility, reducing blood pressure variability, supporting brain circulation, and improving the body's overall ability to regulate pressure dynamically. The evidence for this is not ambiguous. It is robust, consistent, and reproducible across decades of research. So here is where I want to land. The new rules for blood pressure in seniors are not really about abandoning numbers. They are about understanding what those numbers mean in the context of your age, your biology, and your individual physiology. They are about recognizing that the old universal target may not be your target. They are about understanding that both sides of the pressure spectrum carry risk too high and too low. And they are about shifting the conversation from hitting a goal to building a body that is genuinely resilient at the cardiovascular level. You are not powerless here. I want you to hear that clearly. The most important message I can give you today is that the trajectory of your cardiovascular health at 55 or 65 or 70 is not fixed. The arteries have more capacity for improvement than we once believed. The brain has more capacity for protection than we once assumed. And the actions you take starting not next year, not next month, but in the next week matter in ways that will show up in how you feel, how clearly you think, and how independently you live years from now. If you have a blood pressure cuff at home, take it out this week and start logging readings consistently. If you have not spoken to your doctor about your individualized blood pressure target in the last year, make that appointment. If your diastolic number has been running low or your readings have been highly variable, bring it up directly. You are your own best advocate in that exam room, but only if you have the information to ask the right questions. And that is exactly why I make these videos. If someone in your life, a parent, a spouse, a close friend, is over 50 and managing blood pressure, please share this with them. This is the kind of conversation that belongs at the kitchen table, not locked inside a cardiology journal. And if this channel is new to you, I hope what you heard today gives you a sense of what we stand for here at BioSecrets. We are not here to alarm you. We are here to inform you honestly, carefully, and in a way that actually helps you live better. Hit the subscribe button if you have not already. Leave a comment below and tell me what is one thing from today that you are going to bring up with your doctor. I read those comments. Your questions shape the conversations we have here, and I will see you in the next one. Take care of yourself. You have earned it.